The next speaker is Dr. Ramón Gómez Meda, who is actually joining us from Spain online. That's perfectly fine for this hybrid event. He's also a speaker at the conference today in Spain, so we were fighting for him to get him here. But I think we are very fortunate to have 9 out of 10 speakers on site here in Zurich. So Ramón is joining us online, and I've just heard that there is still a connection problem, so I'm not sure if we already have him here on the screen. Actually, it doesn't look like Ramón is here. So let me just give you some more background information about who... Ah, wow, Ramón. No, that's not him. Not live, at least. So let me give me a bit more background information about Ramón. And I think what's really fascinating about Ramón, that he is a dentist who is trained as a surgeon, periodontist, prosthodontist, and also as an orthodontist. So he really has this perfect multidisciplinary approach. What is also amazing, he has an Amann-Giabach milling machine in his office. So he really can benefit from all the advantages of this matrix implant system, and I think it's also just outstanding. His clinical work, his documentation, his photos that he's taking, and wow, Ramón, that's perfect timing. I just introduced you. Can you?
Hello, Jorge.
It's Sandro.
Sandro, sorry.
You don't see me. You don't see me. That's okay. I can see you.
No.
You're here, big on stage. We can see you clearly. We can hear you. I just introduced you, and actually, I don't welcome you to the stage here on site, but I welcome you to the stage here online. Actually, we recorded his lecture yesterday evening because we didn't want to risk any connection problem. But Ramón is live with us here today. So for the Q&A session, he will be back on the screen, and we will have a live discussion with you, Ramón. But now first, let's play your TRI talk with the topic, how you revolutionize patient care with the matrix system in your beautiful practice in Spain. So I'm very much looking forward to your TRI talk, Ramón. Thank you.
Hello, dear colleagues. I'm Ramón Gómez Meda from Spain, and it's a real pleasure to be here with you, talking about the new connection, about the new implant, about matrix implant by TRI. And my lecture is going to be about immediate implants and what we did many years ago and what we are doing nowadays. And because digital dentistry has revolutionized the way we are looking at our patients, how do we work nowadays? From the intraoral scanners to the milling machines, printer machines, we are able to finalize our works much quicker. Of course, I don't have time to speak about about every single detail of immediate implant placement. You have to consider many little details. How much bone do you have? What is the condition of the soft tissues? What is the position, the 4D position of the implant? And of course, it's not only about surgery, but also about how you reshape the emergence profile of the implant-supported crown, and this is quite paramount in order to obtain a natural emergence profile of the implant-supported crown. And for that, many times, not always, but many times, mainly in patients with a thin phenotype, we are gonna to need a connective tissue graft. We will try to execute minimal invasive surgeries, if possible flapless, and of course many times we will fill the gap between the cortical plate and the implant with biomaterial. So this is more or less what we are doing in our office. For the last 20 years we've been placing immediate implants with a very high predictability, but many years ago we had to realign the old crown or the new temporary restoration in order to provisionalize this implant immediately. You see that I keep as a flapless surgery I do a smooth incision with micro surgical approach, and if necessary, mainly, as I said before, in thin phenotypes, I graft the tissue, a connective tissue graft, place a connective tissue graft from between the cortical plate and the mucosa. So it's a good thing to speak about the surgical details, but it's also important, as I said before, how do you shape or reshape the emergence profile, or how do you choose the right abutment in order to preserve enough space for the biological width to be reestablished. Jonathan Esquivel, Dr. Blach, and myself wrote 2 papers this year about this topic, about how to reshape the emergence profile of a temporary restoration or a final one. And there are 3 main areas. The C area, crestal zone. We have to preserve enough space for the tissues, for the tissues to reestablish the biological width. The E area, that's the aesthetic area, the one that defines, outlines the transition area, the aesthetic transition area, the final shape of the soft tissues, and the bounding area is the least important, the one that connects the C and E area. This was done many years ago in the same way, but using an analog way, using burrs and resin, and it took us a lot of time, sometimes more than half an hour. And of course, these are the papers I was speaking about before. Of course, if you do everything in the right way, you will get a nice result. As you can see here, we were able to go from A to B, from the left to the right, quickly, using a immediate temporary restoration, and that we redefine in an analog way. That way we avoided a gingival recession on the back side of our implant. I published many papers 15 years ago about this, and this was published in the magazine of Spanish Society of Periodontics, and you see the follow-up 10 years later. You see how do we use the connective tissue graft, not only the back side of the implant, but also supporting the base, the papilla, in order to avoid the collapse of the papillae in this patient she was a dentist. And 10 years later, you can see that even with this PFM crown, this crown was done almost 20 years ago. This is the 10-year follow-up, but this was done 20 years ago, more or less, and this is still working. It's a PFM restoration. And the question is, do I have only connective tissue graft on the back side of my implant, or do I have bone? And you can see on the CBCT that I have bone as well. I have soft tissues, but I have bone. Okay. But at the time, the problem using this analog procedure, it works, of course this analog workflow works nicely, is that you can reconstruct the cortical bone plate that's in the implant placement. You can do many things. You can graft not only connective tissue, but bone graft, the biomaterials, whatever. But it takes a lot of time to realign the temporary restoration and to reshape, to polish, to adjust the contact point, the occlusal, the occlusal contact points as well. So it's hard. It takes a lot of time. Sometimes we stratify a little bit the composite. And if I show you a quick video, you can see that it's a little bit tiresome. And this was dramatically changed with digital dentistry. When we started using intraoral scanners, we eliminated this kind of procedures that, once again, I repeat, of course, they work. So, of course, I'm talking not only, here I am focused on the single cases, single tooth, but this can be applied in full arches as well. And in full arches takes even more time to reshape and to polish, to redefine the emergence profile of temporary restoration. More or less, summarizing, every time I place implants immediately, I take out the teeth carefully, I place the implants, if possible, with a surgical guide. I use biomaterials between the implant, the cortical plate, and soft tissue grafts if necessary, if this phenotype is quite thin. And finally, I load them immediately. It allows me to change the transition area, the way the gingiva is gonna look. And this is my main goal, to deliver a high quality restoration and to reshape the tissues, the soft tissues, in order to end up with a more natural emergence profile of the final restoration. You see that here I had a missing lateral incisor, and finally the result is quite acceptable and the patient is quite happy. Evidence-based dentistry changes every single year, and it means that we have to adapt our workflows to the new technologies. And with scan bodies and intraoral scanners, we started to mill immediately the restorations, and this saves us a lot of time. We are also able to place the implant digitally driven throughout the surgical guides, printed surgical guides. This is a clinical case where the premolar had to be extracted. The implant was placed immediately and the cortical bone plate reconstructed, and the scan body used in order to determine the 3D position of the implant. Then the temporary restoration is easily milled by the Amann-Girrbach machine, but we need a die base, 3 die base, in order to cement the temporary restoration to this abutment that can be dyed. This is the final temporary restoration, and we harvested a connective tissue graft from the tuberosity in this clinical case. So this is the final result. We saved more than half an hour reshaping, polishing the temporary restoration. After a couple of months, you can substitute your temporary restoration for your final one. So you are able to finalize in 2 clinical steps, and this in 2 appointments. 0 is the day you see the patient for the first time. The first appointment when you do the surgery and the implant placement, and the second appointment when you change that temporary restoration for the final one. But we still want to eliminate the T-base if it is possible. And now it is possible with this new design connection. With this implant, we have a new connection, a connection that it is very easy to work with, and a connection designed in order the machine to properly to get a predictable result, a nice adjustment between these rounded edges of this connection and the head of the implant. That way we can work directly with the PMMA or the zirconia material to the head of the implant. And the shape of the tissue level implant once again is redefined, and this is nice because we have a concave shape in order to allow for more space more space for the soft tissues around the neck of the implant. You have a wider connection for 0.5 or a narrower connection in a pink color. So we have many advantages, and now we can eliminate the analog workflow and to keep fully digital the workflow, to manufacture the restoration directly here at the office and without even using T-base. This is very nice. Of course, I don't have time to show you many different cases. I'm gonna choose a couple of cases because I have only 20 minutes for this lecture. And this is the first case I want to show you where 7 had to be extracted, and we planned everything digitally. In that way, we save a lot of time during the implant bed preparation. The implant is properly prosthodontically driven. And with the scan body, we determine the 3D position of the implant. We place a healing, we screw a healing cap in order to fill the gap with biomaterial, and immediately we design, in this clinical case, we design a healing, individualized, customized healing abutment, because here we didn't have the possibility to load the implant immediately. We didn't have enough primary stability. But look at the design of the connection on the healing cap that was immediately screwed onto the head of the implant. That way, we were able to preserve the socket at the same time we placed the implant, saving lots of appointments to our patient, and of course reducing the morbidity. After several months, a couple of months, 3 months, if you want to wait a little bit more, you finally change that restoration for the final one. You don't even need to re-scan the position of the implant because you already have the STL file. Then the only thing you have to do is to screw the new monolithic zirconia crown onto the head of the implant, and everything is finished. You see the second crown, the 7-1, and the implant with the final crown without using any T-base, any intermediate abutment. You are saving time and you are saving materials. Of course, you have to consider the right shape of the emergence profile you want for the final restoration. I recommend you to read this paper written by us. I spoke about it before. So this was before, during the surgery, and afterwards, and the result is quite nice. And in the Apayot, with a different approach, now leaving the implants without any temporary restoration, because I know that some of you don't want to load the implants immediately, no problem, or you cannot if you don't have enough primary stability. You see that I had 2 premolars that had to be extracted, and once again we planned everything virtually. We printed the surgical guides here at my office, and we very quickly placed the implants in the right position. Everything was left to heal for a couple of months. We grafted the gap with a sponge collagen, with a collagen sponge, without any connective tissue graft. These are the implants I placed here. And what you can do is to register the implant position even if you don't load them immediately. I prepared 2 temporary restoration, but for 2 months later, because I didn't have the right emergence, the right primary stability. And as I said before, consider reading this paper we wrote, because you will get a nice, clear idea of what we are talking about. This is the temporary restoration that is screwed immediately onto the head of the implant. This is a PMMA immediate restoration. Look at the healthy tissues we get without reshaping several times the soft tissues. And finally, the only thing I have to do is to substitute those crowns for the zirconia, monolithic zirconia crowns. You see the connection, the matrix connection that is working till now very properly. And you see, on the left, the right emergence profile I got thanks to the tissue level emergence profile of the implant, head of the implant, and the PMMA interim restoration I used. This is the moment I am screwing the final restoration onto the head of the implants, and the final result. Look at the healthy tissues I got very quickly in only 2 appointments, working only 10-15 minutes. So This matrix design, this new connection is changing the way we are working nowadays. It is doing our job easier. It has many advantages, but the main one, in my opinion, is the efficiency. It's much easier. It's easier and easier to work every day with immediate workflows. And all of it combined with the intraoral scanners, printers, and milling machine is something that has revolutionized, in my opinion, dentistry. There is no magic in magic, it's all in the details, said Walt Disney. Thank you so much for your attention. You are free to visit me anytime you want, or you can write to me and ask questions throughout email or whatever, or social networks. Thank you so much, and I want to thank TRI for the kind invitation.
Thank you so much, Ramon, for your great TRI talk. I hope you heard your applause. I can see you, I can hear you. You can see us and hear us as well.
Absolutely.
We have beautiful presents for the speakers. I cannot give it to you today, but the next time we meet, I will give it to you. We have also received several questions. First one I would like to ask you is from Dr. Kitahara from Japan. Why don't you use zirconia, individual healing components like the Joel and Shoa have shown in their previous lecture?
Well, because zirconia has to be sinterized, you know. So to work with PMMA, I mean PMMA temporary restoration is quicker, more simple in my opinion, and I didn't feel any kind of difference in the soft tissue behavior because consider that I'm placing mainly the tissue level implants. Then the connection is far away from the bone. So in the end, I don't see any difference, and I'm saving money, and I leave the zirconia restoration for the final prosthesis. But you can't finalize with the zirconia restoration from the beginning. It's an option, but the problem if you place the zirconia restoration is that you don't have the possibility to reshape anymore the soft tissue. So if you want excellent results, mainly in the aesthetic area, that is difficult. You know, for the posterior area, you can do it, but for the anterior area, it depends on your goal.
Thank you. I think the second question is also about tissue healing. You showed different cases. In some cases, you still use the titanium healing colors that we also provide for Matrix. In other cases, you used actually the individual healing abutments. Do you, Dr. Storelli from Italy is asking, do you see a difference if you use like this individual or the standard healing components on the long-term result, the long-term clinical result?
Well, it's a good question. You know, as I said before, it depends on the clinical situation. It depends on the patient you are treating and the teeth, that has to be replaced. Because if, for example, in the case of the premolar, the profile of the premolar is narrower than the one from a molar. Then with the premolar, you can use any kind of healing cap. And it's easier to go from there to the final restoration throughout a temporary restoration. Even you can save the temporary restoration if you are working in the lower jaw. But in the case you are placing an implant in a molar, like the first clinical case I showed, the problem is that the emergence profile of the molar is very, very wide. And if my healing cap is very narrow, then I will have to go through another temporary restoration before placing the final restoration, the physis. So the customized healing cap is a temporary restoration cut in half. In that way, I'm saving time. I don't know if I explain myself. It's a temporary restoration. I'm keeping the anatomy of the soft tissues. You can use it for a premolar, but it's not so important because the premolar is narrow. And for a molar is a nice idea.
Thank you, Ramon.
Of course, it could be. I would need more time in order to explain every little detail.
Thank you.
And you have to consider the primary stability of the implant, of course, because if you have a very, very good primary stability, you can do many more things. But without enough stability, you cannot.
Yeah. Maybe one last question. We mostly know you from using bone level implants. You use in the past more bone level than tissue level implants, and we know your papers and your studies about this shape and design of the prosthetic restoration, the C, B, and E area. Now, a lot of this research was done with bone level implants. Now you use a lot of matrix tissue level implant. So how can these results from these papers be applied, first of all, from the bone level to the tissue level, and from an implant system with an abutment to the matrix system that has no abutment?
Well, another difficult question. Okay, first of all, I have a very long experience with tissue level implants, more than 20 years of experience. I love tissue level implants, but I don't use them every single time, of course. Secondly, the two papers published with Jonathan Esquivel and Dr. Blas from University of Louisiana, University of Penn, speak about not only bone level implants, but also tissue level. Thirdly, it should consider the Polish collar of the tissue level implant should be considered as an abutment, intermediate abutment. Then I'm saving that intermediate abutment with the tissue collar, with that Polish collar. And that's the reason sometimes I place the implant supracrestally or just crestally, but not so deep into the bone, because it's another way of working. So in that way, finally, I have to say, I get the biological, functional, and aesthetic result I want, avoiding to use any T-base or any intermediate abutment. I don't know if I try to answer the question very. I try to make a long story short, because it's difficult. I don't know if I answer correctly the question.
Just one last, no, I think it's clear. One last question from myself. You have used our bone level and tissue level implants. Now you have just used matrix tissue level implant. Do you think that the matrix tissue level implant is a universal implant for you, that you can really treat every single patient in every single case, or do you still see the need to use matrix bone level implants in some cases?
I feel so. There are some tissue level implants very difficult to use in certain circumstances. For example, in order to replace very narrow teeth, lateral incisors, upper lateral incisors, lower incisors. But with matrix implant, tissue level implant, we have the possibility to solve that problem, narrow design. And not only that, that collar is concave, and it allows me to preserve, to keep more space for the soft tissues around the neck of the implant. So with this implant, I can solve many, if not all, the situations, the clinical situations.
Thank you. And we just have one minute left. So let me pick the last one. How do you treat the crowns, the zirconia crowns in like the C, B, and E area? Do you polish it? Do you glaze it? How do you treat the different areas of the full zirconia crown that goes directly on the implant?
Yeah, we don't glaze, forbidden to glaze the connection, of course. And we glaze the rest of the area, but we polish. Mainly we polish the zirconia, We glaze the supragingival area mainly, but the subgingival area is mainly polished.
Great. Thank you so much, Ramon. I think that was very clear. We hear you perfectly. We saw you perfectly. Thank you so much. Have a nice day, Spain, and hopefully see you very soon in person. Bye-bye, Ramon.
Thank you so much, Sandro. Bye-bye. Thank you, everyone. Thank you so much.